Welcome to the Oncology Voice Network podcast, connecting the voices that move oncology drug development forward.
Welcome to the Oncology Voice Network podcast. I'm Dr. Kirk Shepard. This show brings the real-world voices of oncology development to life. Leaders, innovators, patients, and partners who are shaping the future of cancer care. Who represents the patient when they're not in the room? It's a question that sits in the center of almost every decision in oncology, and one we don't ask nearly often enough. Because while the industry talks a lot about being patient-centric, the reality is patient voices are still too often filtered, diluted, or left out entirely when it matters the most. Today, we're joined by Elizabeth Franklin, Head of U.S. Public Affairs and Patient Advocacy for Oncology at Sanofi. Someone who has spent nearly 2 decades working at the intersection of policy, advocacy, and care, pushing to make sure patients are not just heard, but actually represented. In this conversation, we're going beyond the language of advocacy to unpack where the system still breaks, where patient insight gets lost, what it really takes to turn listening into action, and what it means to carry the patient voice into rooms where critical decisions are being made without them. Hi, Elizabeth. Welcome to the show.
Hi, Kirk. Thank you so much for having me.
Let's start with your journey and the moments and experience that shaped how you see patients and why this work is personal and not just professional.
Sure. Thank you for the question. So I'm an oncology social worker by background. I have a bachelor's, master's, and PhD in social work. I like to say I'm a platinum star social worker. When I became a social worker, I didn't necessarily know that I was going to go into oncology. I really cared about social justice issues. I cared about racism, sexism, homophobia. I wanted to make people's lives better, as I think most social workers would tell you. And my very first job was with the National Association of Social Workers. And my boss, our CEO, Betsy Clark, was an oncology social worker. And she completely opened my eyes to this incredible space where all of the issues that I cared about were, I think healthcare and cancer care are really sort of a microcosm for these social justice issues that impact people across the world. And healthcare was an opportunity for me to address some of those issues within this system. And I really just fell in love with oncology. I got to work at the National Association of Social Workers as a lobbyist during the Affordable Care Act. So I moved here 20 years ago. I moved to DC, which is hard to believe. Then I switched to nonprofit patient advocacy. I've worked in hospitals, and then I've been in the pharmaceutical industry for the last 4 years. So I've had a varied career, but I wouldn't trade anything in. It's given me great insights into the patient experience and helped me to do my job the best way possible.
And as you said, you started in social work and policy before moving into pharma. How do you think that shaped you in your job today and how you see oncology?
I don't think, and this may be a controversial opinion, hopefully nobody gets mad at me, but I don't think anybody should be working in healthcare without hands-on patient experience. I think that it is integral to the work that we do to understand how the decisions that we make, whether it's day-to-day decisions at a pharmaceutical company or policy decisions, or no matter what it is, from the micro to the macro, I think it's key that we really understand how decisions and the different ways we go about our work really have an impact on patients. I think about I was working on policy, and until I worked in a hospital, I never truly understood how it impacted patients. And so I think about that every day now. I think about when I'm advocating on a policy issue or when I'm working with a patient advocacy group, how is this going to impact the patients' lives on the ground? And I really think about that. So it impacts what I do every single day. I think about, when I was in the hospital, how would this have impacted a patient? What would the downstream of impacts look like? And I'm really grateful that I have that experience.
And was there a moment where you realized how many patients are not truly represented in the system?
Looking back, I think that the following example is so obvious to me, but when you see it in practice, it really hits home. And it was the first patient that I was supervising patient navigators at the hospital. And we had a patient who was coming in for therapy, and they worked an hourly wage job, right? They were afraid to ask off time from work. They couldn't afford to take off time from work. They thought they might lose their job. And so it's really difficult to tell somebody to come in for oncology care when they're working at a fast food restaurant, when they're working an hourly wage job. We had patients, I used to say the number one thing that we could do to address loss to follow up is have a daycare. We lost so many patients to childcare, right? They couldn't figure out something to do with their children, elder care. I had a patient once who did not want to go through with chemotherapy because she didn't want to lose her hair. And when I dug a little bit more deeply, it was because of her religious tradition, it was because of her husband's wishes. People are really complicated and they're human beings before they walk through the door and become patients, right? Whether it's a cancer patient, whether it's someone living with asthma or diabetes, it doesn't matter. They're people. And so having that first person social work experience, seeing the world in which they live in, they thrive in, and the challenges that they experience is really important.
So perhaps challenge the idea that patient advocacy is a support function and redefine where it should truly sit in decision making.
I sort of I say this about patient navigation a lot, and I'll talk about navigation, I'm sure, as we continue the conversation. But people used to say that it was value added. And I absolutely disagree. I think that it's integral. None of us would have a job. I don't care that if you're an oncologist, a nurse, a patient advocate, or somebody on the commercial side, or a scientist. None of us would have a job if it weren't for the patient. And so to hear people say that patient advocacy is a support function, honestly, I think that you might as well not have patient advocacy because I think that people can truly tell when a patient advocate is there for the right reasons, when they're truly, I know we'll talk about that term patient centricity, which is so overused, but people can tell. People know when patient advocacy is a function that has a true impact, that's close to power, right? It's not sort of buried down in the organizational chart. It's not an afterthought. It's not just sort of a nice, fuzzy, warm, nice to have, but it's a function that actually sits in a position of power that feeds up through decision makers and that I can actually have an impact on all of the decisions within the company.
So we were very fortunate to have you write the chapter on patient advocacy for Voices of Oncology, our book that's recently been released. And in that chapter, what did you most want people inside the organizations to understand?
I think I'll go back to what I said before, which is that patients are people first, right? We are not talking about sterile environment in which, we think about, let's say, clinical trials. That's not how the world works. That's not how patients walk through doors and receive care. They walk through doors and they're worried about their kids, their parents. They're worried about affording transportation. They're worried about feeling sick, losing their hair, all of these things. So, I think that when we often make decisions at all levels, whether, again, we're a healthcare provider, whether we're in a drug company commercializing a product, whether we're at a patient advocacy group, every decision that we make, we need to take into account that patients are not, we don't pull them out of test tubes. They come with very full lives, and we need to understand the nuance that's behind that. And we need to make efforts to address and assist patients so that they can receive the therapies. Because, if access is not available, if patients can't access therapies, what's the point in making them, right? We have to meet patients. We have to listen to patients. So that would be my other part. Understand that patients are complex human beings that come in with whole lives. And when I was working more on the social work side, we often wouldn't even say the word patient. It feels a little sterile. We might say client or just a person living with a disease, right? I hate to say the term cancer patient because cancer defines that, right? It's someone living with cancer or someone living with a chronic illness, not letting cancer define the person, but understanding that we need to approach them where they are and help them in whichever way makes the best sense for them.
And let's talk about bridging the gap and where perhaps it breaks. Expose where the patient voice gets diluted, filtered, or lost as it moves across partners and functions.
I think the patient voice gets lost. And I say this writ large. I feel like my company is very patient centered and we do a very good job of making sure that the patient voice doesn't get lost. But I used to say all of the time when I worked in nonprofit patient advocacy, and I would say this to pharmaceutical companies, I would say this to insurance companies, I would say this to PBMs, doctors, whoever I was talking to in the healthcare system. Work it out. Don't put the patient in the middle. So I think sometimes when there are fights in the healthcare system, oftentimes it's the patient who pays the price. It's the patient who has to deal with the brunt of that. And so if you're trying to lower costs, don't put that at the feet of the patient for lower costs for the company. If you're trying to make as much revenue as possible, that's not on the patient, right? Let's figure this out. We know that healthcare is complex. We know that there is a lot that needs to be done. It's not a perfect system by any means. And what really upsets me is when patients pay the price because we can't figure out as a system how best to serve them.
So you know that most organizations now in pharma are very excited about getting insights from healthcare physicians, from policymakers, and patients. But is the system designed to truly absorb patient insights as you see it now, or is it just acknowledging it?
It's a hard question because what do we mean by the system, right? I think writ large, if we're just saying the big system as healthcare in the United States, at least, is it built to support patients and, respond to their needs? No, it's not. It's too complex. Every time I go to the doctor, I think, how does the average person do this, right? Even if it's not the oncologist, even if I'm just going to a doctor, I get nervous and I have a PhD in social work and I've spent my entire career in healthcare. And I tell docs this all the time, sort of intellectually or on the surface, I'm not afraid of my doctor. I feel like I can go in and have a thoughtful conversation and express myself in a way that makes sense. I mean, Kirk, I'm talking to you and you're a physician. I feel totally comfortable having this conversation. That goes out the window when you're diagnosed with cancer. It's just too complex. And we expect the average person to understand complex scientific information, be able to think on the worst day of their life or the worst period of their life, be able to make decisions. I think that in the best case scenario, that's difficult. When people have resources and the ability to navigate systems and a support system. And, I get calls all of the time when someone is diagnosed with cancer and I say, I've got you. We're going to find the best doc in the country to help you deal with pancreatic cancer. We're going to find, what do you want? What's important to you? I'll help you. Not everybody has that. And so the system is designed to help people with the best resources, the most resources, the ability to navigate. I don't think it's built for everybody. And we absolutely have an obligation to change that.
Who benefits from the systems today? I mean, is there any particular group of patients that are getting left behind, particularly as far as all the processes across designing a new drug? How do early decisions, trial design, eligibility, endpoints shape who ultimately benefits? And how could patients perhaps be more involved in this?
It takes me back to what originally brought me into social work, which is the social justice component, right? By and large, we've seen over the years, the healthcare system was built for someone with means to navigate the system. That means someone who English is their first language, someone with financial means to be able to navigate it. I have a friend who is participating in an NIH trial, and he's paying his way to go from his home state to NIH. And I said to him the other day, how does that feel? And he said, I feel incredibly fortunate that I can do this. And I know not everybody can. You need to be able to speak the language. You need to have a support system, right? We think about the most promising therapies or the most exciting therapies that potentially are a cure, like CAR T. When I was working at the cancer support community, we would often talk to CAR T patients. You have to have so much in your corner. You have to have a support system. You have to have the ability to go and stay at the hospital. You have to have transportation ability. You need to be able to navigate that system. And so that's just not the experience for, I would argue, most people in this country. I think it's an elite few who have those resources. And so when we think about who the system was built for, it's an elite few. It's people who have the resources and ability to navigate. In drug development, think about we often call people super patients, right? Let's ask so and so. Well, we know that person because they've been able to carve out time in their schedule. They've been able to take that time to provide feedback to us. They have been able to figure out the system and, the fact that they're connected to me, they've been able to go on LinkedIn and find me and know who I am and how to get in touch with me. And so it's a really complicated system. And, I feel very lucky to be able to help people navigate it, but not everybody is able to connect with a Kirk or an Elizabeth. And so we still are seeing too many people who look the same, who talk the same, who have similar experiences in this country being able to access the best care.
And let's talk a little bit too about exploring the weight and responsibility of representing patients in rooms where decisions are made without them. A lot of times, this is the family members or friends. I mean, what does it mean to represent patients in rooms where a lot of times they're not present?
Yeah, at first it's an honor, right? I don't take lightly what I get to do every day. I am extraordinarily fortunate that if I were a social worker working in a hospital, I would say this. If I were any sort of role that I've had in my life, I felt incredibly honored and lucky to be able to represent the voice of the patient. What I tell myself is, I especially earlier in my career, I've sat back and felt even a little bit intimidated. I'm sitting in a room full of physicians or folks from insurance companies, PBMs, industry, pharmaceutical companies, and something wasn't sitting right with me, right? Something was said that I just didn't agree with. And I sort of sat there and thought to myself, should I speak up? Am I gonna be the person who messes up the flow of discussion? Am I, for lack of a better term, am I gonna be the party pooper who comes in and says, you guys are wrong. This is not good for patients. And as much, I sit there and I think, I can't. If a patient was sitting here listening to me or watching me, how ashamed would I be of myself if I didn't speak up and represent their voices faithfully? And so it takes a lot for a patient to step forward and to share their story, to make themselves vulnerable. Who wants to talk about when they're sick? Who wants to talk about when, a part of their life that is likely terrible? They're doing it because they want to improve the lives of others, and I feel like that's the responsibility that I have when I'm in rooms to make that voice heard. So it's an honor, and anytime I've ever felt, again, hesitant to speak up, I tell myself, "No. If there was a patient sitting there, you absolutely would speak up, so you better do it."
So, a lot of companies call themselves patient centric, and perhaps it comes sort of a checkbox. Comment on that as far as the industry's language, which a lot of times outpaces its actions, and why meaningful change is still inconsistent. I mean, the term patient centric is everywhere. Where has it lost its meaning and how is that happening? And what can we do to correct it?
I agree. I think the word patient centricity has lost the meaning, and I think when everybody uses a term, what does that term mean anymore? I conjure an image in my mind when you say patient centric, and it's of a circle where a patient's at the center, and then you sort of have the community going out from there, the doctor, their family, the system. When I think of that image, I think about everybody looking at the patient versus the patient dictating and saying, this is what's important to me. I run the show, right? And so it may just be semantics that patient centricity is overused. And so it doesn't make sense for us to use that term. But, what does it really look like in practice when it's meaningful? I used to get this question all the time when I worked in nonprofit patient advocacy. What makes a good partner? What I'm going to say first is somewhat intangible, and it's that patients know when you are real. Patients know when you mean what you say. I knew when I was working with the pharmaceutical industry or physicians or the insurance industry that people who were just doing a check the box exercise, I could see through it in a second. 10 seconds into the conversation and I knew. And I was rarely proven wrong, right? What that looks like is my team and I are at patient advocacy events on nights and weekends. We have patient advocates that we can call and ask for feedback. I try not to make any big decisions. I try not to even draft anything without talking to a patient first. I was actually recently working on a project around building in patients as partners into research projects because we were getting a lot of research proposals from researchers who were saying that they were quote unquote patient centric, but their patient centricity was doing an interview with a patient, hosting a focus group. Who developed that focus group guide or interview guide? Who helped you come up with a concept for the research project in the first place? You should have a patient at the very beginning, and that rings true too for clinical trials. Don't go to patients in phase 3 and say, "How can we make this better?" And it happens, and not everything is perfect. Research is difficult, it's complex, it's expensive, so it doesn't always happen this way. But if you start with patients from the very beginning, that to me is, I'm not gonna use the word centricity, patient-focused, patient-first, patient-directed. If we can get to the point where it's patient-directed, I would be incredibly happy. I really think it's building the patient into every decision we make and not going to a patient at the last second as a check the box exercise. We cannot do that.
So really, you're talking about redesigning the system in a sense with patients with their truly at the, sorry to use the word, at the center or whatever word we want to use. And are there specific things you could go after right in the beginning that would be important as far as changing?
If I knew how to redesign the system to best serve patients, I feel like I would be a much wealthier woman, Kirk. I would be famous. I would be writing books. So I'm not there
Well,
yet.
you are writing books.
I am right. That's true. That's true. I've written a chapter in a very important book, but I would write a book that everyone would follow, and we would redesign the healthcare system. I think it's aligned with everything that I just said. If you ask patients what their values, needs, and preferences are, not just once, on an ongoing basis, and you make sure to incorporate that in everything that you do. I'm a big believer that the business follows if you do right by patients. If you're chasing a dollar, which many in the healthcare system are, it's eventually going to fail. It's eventually going to fall apart because if you don't know what patients want, if you don't attend to their needs, I don't believe in it. I think that if you do what's right by patients and you truly integrate them into every step of the way, is it more time intensive, resource intensive, labor intensive? Absolutely. It's a lot easier to do your job and maybe do a check the box with a patient or say something to them afterward. It's a lot harder to integrate them in every step of the way, but it will absolutely pay off in the end because it's the right thing to do, most importantly. But I also believe now, sort of shifting from the nonprofit space or being a social worker on the ground, I do think that the business will follow.
And I agree with you. I'm thinking about now the book and the authors. And when we were done with the book, everybody was thrilled with the results. And they said, "Well, is that it? Is there something else?" And that's when the idea for OVN or Oncology Voice Network, which you're now speaking on, became part of what we were doing. So, do you see that as an important role to be more connected, cross functional with communities, as perhaps accelerating this shift we were talking about?
Absolutely. I love that OVN has come about. I think it's such an important step after writing the book. Look, I'm a big reader. If I was in my home library, you would see a ton of books behind me. But we know that that is not a way to reach everybody, right? Whether it's through time, resources, not everybody's going to be able to pick up the book. But people do listen to podcasts. People do read articles or whatever it is. I think that if we can adjust and make sure that information can reach people where they are in the format that they can receive it, it's really important. And kudos to you, Kirk, and the team for including me in the book, not because I think that I deserve to be there, but somebody needed to write about patient advocacy, and you easily could have skipped that. Somebody needed to have this podcast episode. You easily could have skipped it. You could have focused on medical or commercial or market access, all of the incredibly complex pieces that go into drug development and delivery. But you made a conscious decision to include patient advocacy. And I think that says a lot about you, about the project, and about OVN. I feel like that's what's going to continue to push this and keep it relevant to patients because otherwise they wouldn't see themselves in this discussion.
It's interesting you mentioned that because when we started reading the reviews in the book, when it was selling on Amazon, and I was surprised at how many people were reading and reviewing it who are not in industry, who are not MDs. They were patients and patient advocacy, talking about how they now understand more about what it's about and how they can perhaps affect the system. So I agree with you. I mean, this is such an important area, and your chapter was so wonderful that we really appreciate you being part of that team.
Thank you. I appreciate it.
So, if there's one change in the industry that we cannot longer afford to delay, if we're serious about serving patients, what would that change be?
So I'm going to cheat on this question by giving two answers, but I'm going to split it into micro and macro. I think from a micro perspective, it sounds easy when I say listen to patients, but it's not. It is time consuming. It is resource consuming. I remember when I was at the cancer support community asking industry to integrate, patient reported outcomes into their clinical trials. And it was shocking to hear them say it's really expensive. It could cost us $1 million to integrate one PRO. We don't want to overburden patients. It takes a lot of time, energy, and resources, but you have to do it, whether it's clinical trials or whether it's, whatever the initiative or project, drug pricing or bringing a drug to market, what is most important to patients? Because once that drug comes to market, if it doesn't make sense in the lives of patients, they're not going to use it. They're not going to talk to their doctor about it. They're simply not going to use it. So, listening to patients, it sounds like such a simple piece of this, but it is incredibly complex and requires a lot more than it sounds. And then, two, from a macro level, which I think will tie from the other components in the book and the other authors, is make the system simpler, right? And it goes back to what I said about don't put patients in the middle. When we put undue burden on patients, whether it's utilization management or other tactics to lower the cost of care, it really makes patients' lives so much more difficult. And especially if you're living with cancer, I used to always say, one day I will do a study on the psychosocial burden of appeals. Getting on the phone with your insurance company when you have cancer to fight and try to overturn a decision is absolutely awful. I can't imagine a worse use of time when you don't feel good, when you're fighting for your life. We have to make the system simpler. We have to stop putting patients in the middle of these fights because we need to figure it out and they shouldn't suffer as a result. So, again, I think from a micro level, it's listen to patients and do what they tell you. That's the other piece of this. Listening is not enough. Something needs to happen. It needs to be operationalized after we listen. I think a lot of people listen and they have best interest at heart, but we need to do something with that information once we listen. And then the second piece is the bigger piece, which is we got to simplify the system and we have to stop harming patients by trying to come up with new ways to save money or really do what's right by patients, and the business will follow.
What a great comment to end the podcast with, Elizabeth. Thank you for being with us today, and thank you for your wonderful and inspirational work and dedication to both patients and patient advocacy. Your role in oncology drug development is so important. Thank you.
Thank you so much, Kirk. I really appreciate it.
That's it for this episode. I'm Dr. Kirk Shepard. Thanks for listening and for being a part of the conversation that's moving oncology forward.